First speaker, Dr. Stuart Lavery. Dr. Lavery is a consultant in gynecology and reproductive medicine and surgery at Hammersmith and Queen's Charlotte Hospital in London. He's the director of IVF Hammersmith and also the HFEA person responsible the unit. He has international reputation as a center of excellence for assisted conception and one of the largest IVF units in the UK. He's an official spokesperson for the British Fertility Society and have received media training for that role. Dr. Lavery is an honorary senior lecturer at Imperial College Medical School and is the supervisor for the assisted conception module of their MSc course in human reproductive biology. So, Dr. Lavery.
Good morning, everybody. Thank you, Peter, for that very kind, lengthy introduction. It's a great pleasure to be here in Goa, and I'm grateful for the organising committee in Gotham for the invitation. Hopefully my talk will appear on the screen soon. Yep, that's the one. Wonderful. All right, so this session today is devoted to oocyte quality, and I've been asked to talk specifically on stimulation and oocyte quality in patients with polycystic ovaries. This is something that probably everybody in the room will have considerable experience on. Polycystic patients are very commonly seen in the clinic, and they present us with a therapeutic challenge, both in terms of maximizing their pregnancy rate, but also specifically in these patients in doing so in a safe manner. Probably the worst thing that we see in our units is the epidemic of multiple pregnancy and also ovarian hyperstimulation syndrome. And this is a double challenge that we face in the management of these patients. So over the next 20 minutes or so, I'm going to talk a little bit about oocyte quality in these patients, a little bit about what the evidence is to show that there is problems or compromise in the oocyte quality, spend a little bit of time talking about the mechanisms underlying those abnormalities, and then talk about how that then impacts on our management with these patients and the different stimulation regimes that we can actually encounter. I'll touch briefly on pre-stimulation treatment, a little bit about recombinant or urinaries. We've already heard the talk this morning on the addition of myo-inositol, and then cover some alternative approaches, and finally finish off by looking at some IVM. So we'll try and condense that, and I'll try and give you just the main points. So we all know that polycystic ovaries, as I said, is very common. It's not a very well understood condition, despite its preponderance and despite the fact that it's been around for a long time. This painting is 300 years old, showing a patient with rather severe polycystic ovaries breastfeeding a baby. We know it's associated with menstrual dysfunction, irregular periods, irregular ovulation, as well as subfertility and hirsutism. There are well-described biochemical parameters of hyperandrogenism, hyperinsulinemia, and LH hypersecretion, coupled with the ultrasound features of increased volume and increased follicle number, as well as an echodense stroma. What's the evidence, though, that the eggs that we obtain from these patients are suboptimal in quality? Well, we know we get more eggs. There does seem to be some evidence of poorer quality, both seen in the eggs and seen in the embryos. It's perhaps better described as problems with maturation, and I'll come on a little bit to talk to you about aneuploidy issues in the chromosomes of these eggs. We do tend to see lower fertilization rates and cleavage rates, some lower implantation rates, and certainly it's well accepted that there are higher miscarriage rates. There have been reports from Uman showing that you see increased embryonic fragmentation and decreased blastocyst formation, and certainly I think everybody would accept the elevated number of immature oocytes. What are the proposed mechanisms by which we may see this reduction in quality of the eggs of these patients? Well, the first thing one might think is, could it be a problem with the actual chromosomes of the eggs? Are we seeing problems with aneuploidy? And indeed, the initial evidence from Santiago Monet's group in New Jersey and Luca Gianaroli in Bologna was that you did see increased rates of aneuploidy in these patients. But this was based on very early studies using fluorescent in situ hybridization. sometimes only using 3 chromosome analysis or 5 chromosome analysis. So I think these earlier studies we must treat with a degree of caution in terms of assessing whether there indeed was a full chromosome complement aneuploidy. And indeed, if you look at Weghoffer, who works in the same group as Monet, who's published their later data in 2007, looking at comparative genomic hybridization, so a much more full assessment of how many chromosomes are abnormal. And in fact, he showed that in patients with polycystic ovaries, you got more eggs and more euploid embryos than you do in patients that are not PCO. They did still see a small reduction in pregnancy rates, and they did see an increase in miscarriage rate. And again, bear in mind that these were patients that were receiving PGS, and so nominally were having euploid embryos returned. They were still seeing the increased miscarriage rates in the polycystic patients. This is our own experience. We've been doing pre-implantation genetic screening for many years, and previously we spent a lot of time doing PGS looking at polar bodies on eggs, and clearly this will give us an accurate idea of what's going on in our PCO patients. And we looked at 92 cycles of PGS using just polar body 1 analysis and CGH microarray. I mean, I'm sure most of you know this is an extremely powerful tool that can give you a full chromosome complement. It usually takes about 12 hours to get the result, but you can now very accurately say, or look at chromosome counts across the entire carrier type. And you can see from the table below that we're seeing chromosome abnormalities in all chromosomes, even in chromosomes that you would never see from miscarriage tissue, showing that many of these embryos never get to the stage of implantation. However, I apologize for the way the text has jumped. I moved from a Mac to a PC. However, when we analyze the differences between the polycystic ovarian patients and the non-polycystic ovarian patients in these egg screen groups, we didn't find any significant difference in the aneuploidy rates. Now, this is only 100 patients, but I think it fits in with the data from the Monet group showing that if we are assuming there's an egg quality problem in polycystic patients, this is probably not a chromosomal problem. And indeed, we probably have to look into the cytoplasm if we want to understand why these abnormalities are there. This essentially is just a completion of the data showing that, in fact, the aneuploidy is age-related, not related to the anatomy of the ovary. Okay, so people have looked using the same tool, microarrays, looking at the gene expression from eggs from patients with polycystic ovaries. Again, this is pilot work looking at 9 polycystic ovarian patients and 10 controls. And over 8,000 transcripts from genes were analyzed, and 374 genes were noted to be very significant difference in the amount of mRNA that they produced in patients from polycystic ovaries. These genes were associated with chromosomal alignment and segregation during mitosis and meiosis. 68 of these differentially expressed genes contained androgen receptors and/or perioxome binding sites. So when you look at these eggs, they don't really look significantly different whether the patient is polycystic or whether the patient has normal ovaries. However, they do exhibit different gene profiles, so there are different things going on within these eggs. The promoter analysis suggests that androgens and other activators of nuclear receptors may play a role in this differential gene expression that we see. And therefore, the theory is that there may be some type of genetic underpinning to these reductions in oocyte quality that we see. But these are clearly very subtle and are certainly not chromosomal, but much more subtle at the genetic level. So if it's not the chromosomes, then clearly it's something else. Could it be an abnormal endocrine or paracrine factor, some general metabolic dysfunction that we know is altered within polycystic patients, or specifically looking at the intrafollicular environment, and can we find out these abnormalities by studying what's in the follicular fluid and seeing if that's any different between polycystic patients and normal patients? Certainly, these patients can be relatively FSH deficient at different times of the cycle. This leads to an increased number of antral follicles and increased atresia and premature arrest. And Steve Franks from our own group has demonstrated this, I think, reasonably convincingly. We also know about the hypersecretion of LH, particularly the tonic hypersecretion that can suppress granulosa cell function, which is particularly important clearly during that initial maturation, those 14 days before that egg is ready to be released. And therefore we can see premature meiotic division. And could this be the reason responsible for the increased immaturity of eggs that we see? The hyperandrogenemia may play a role. With increased production within the ovaries, there's a decreased SHBG peripherally. We tend to get follicular arrest and decreased oocyte maturation. I think these extra ovarian factors are reasonably well recognized. We know the hyperinsulinemia can play a dramatic role peripherally in the metabolic profile of the patient, but it also alters the gene expression within the centrosome and the meiotic and the mitotic spindle dynamics. So the peripheral hyperinsulinemia is having a central approach on the egg development and follicular maturity. People have studied what's actually going on within the follicular fluid, and pretty much if you can name a growth factor, it's probably been studied within the ovary. Certainly there seems to be some reasonably good evidence that epidermal growth factor regulates follicle development and oocyte maturation and inhibits estrogen synthesis. And there are significant increases in epidermal growth factor within the follicles of patients with polycystic ovaries. Fibroblast growth factor is shown to be decreased in women with polycystic ovaries, and this is associated with follicle arrest. IGF is interesting because the IGF story, there are studies that show increased IGF and decreased IGF in these patients. So I think it's uncertain because the evidence is so contradictory about the role of insulin-like growth factor. Neuropeptide growth factor, again, the evidence is contradictory. AMH is an interesting one. Initially, during the early days of AMH work, it was clearly shown that AMH levels were increased within the follicles of patients with polycystic ovaries, and it was thought to be associated with follicle arrest, with a reduction in oocyte quality, but interestingly, with no impact on pregnancy rates. There's been more recent work from 2010 actually showing that the eggs that you get from follicles with the high levels of AMH give you better embryos, less fragmentation, and better implantation rates. And I'm going to come back to this because I think many of us are now getting very, very good results in our patients with polycystic ovaries and very high pregnancy rates, as long as we can avoid ovarian hyperstimulation. So I think we need to look quite critically and potentially review our position on the exact impact of these growth factors. As I've said, all of these growth factors, activin, follistatin, vascular endothelial growth factor, they've all been studied quite extensively. And I would recommend an excellent review from Kwao and Feng, which is published in Human Reproduction Update 2011, which in detail goes through the evidence behind each of these growth factors, trying to explain this presumed reduction in oocyte quality.